Chaudhary. She is Director of Glaucoma Services at Eye Hospital and PG Institute, Noida, and has been working in the field of glaucoma and cataract since last 20 years. She authored a book on interpretation of visual fields and numerous chapters for textbooks in ophthalmology, and she was part of national and international glaucoma clinical trials. Her areas of interest and expertise are handling complex glaucoma and cataract surgeries, glaucoma drainage devices and implant surgeries, pediatric cataract and glaucoma management, and now she will be operating and showing us trabeculectomy with MMC application in this 72-year-old elderly gentleman who is hypertensive and is on regular treatment, and he has early cataract in the right eye, pseudophakic in the left eye with advanced glaucoma in the both eyes, and he has open angles on gonioscopy. His right eye optic disc is pale and has 0.75 CDR and inferior notch. And in the left eye, there are many retinal issues like ERM, CME, and PVD. Presently, IOP is under control in the right eye with multiple AGMs like Netalo, Simbrinza, and Lacoma T eye drops. In visual fields, superior hemifield is involved with any early involvement of inferior hemifield in the right eye. And CCT is 463 in the right eye. Over to you, Dr. Reena.
Thank you so much. So, I'll be demonstrating trabeculectomy with mitomycin C. For the convenience, I've already made the conjunctival flap and I'm using the mitomycin C sponges. Normally, I shifted to subconjunctival injection a day before, but here, as I'm seeing the patient today itself, I'm going to use the sponges. So, you take mitomycin C soaked sponges, 2 or 3 of them, and you place it under the conjunctiva, making sure that you have a broad area of mitomycin C contact, and try and keep the conjunctival edge away from it. I'll just center the eye. Just make sure that you pushed it back and keep the conjunctival edge away from the sponges. Timing dekh lena beta. So I'm going to leave it for about 60
this will be
seconds.
2D OT, so you can remove your glasses.
So it's an open angle eye, phakic patient. So usually what we do now is I give a 0.1 ml of mitomycin C a day before in the superior fornix, and then just spread it over with your massage above the lid, and then next day take up the patient for surgery. But here I'm still using the sponges, which works equally well. But you have a better bleb formation and wound modulation with the subconjunctival injection pre-op. Kitne second ho gaye beta? Okay. So we are 30 seconds into the mitomycin C application, and I'm going to wait another 30 seconds before I take it off. For the conjunctival flap, the importance is that you make sure the tenons is also dissected well, and you don't create a buttonhole, and just an adequate amount of conjunctival flap is enough. You don't need to make a very large one. Are we good with the time? Okay, so we have 5 more seconds to go. Okay. So remove the sponges, but make sure that you count and remove as many as you put. I put 3 of them, 2 are out, and I'm going to remove the third one as well. Make sure that you wash it. Make sure you wash it very well with at least 20 ml, 10 to 20 ml of fluid to make sure that there's no residue of mitomycin C. एक और दे देना बेटा, एक और दे दो wash के लिए. Make sure you go under the conjunctiva also to wash the mitomycin C to make sure there are no residues left. So another syringe full of saline to wash it. You can just probably flush it now without the cannula. इसको हटा देना बेटा, 15 number blade दे दो और एक forceps दे दो. So I like to now do the flap. Usually I make a quadrangular flap. Only in situations where there's a lot of subconjunctival scarring or other issues, I might do a triangular flap. Wash कर देना बेटा. Thank you. I hope I'm centered.
Good afternoon, Dr. Reena. Am I audible? I'm Dr. Neelam from...
So you have the rectangular flap being formed here. Wash kar de beta. So So just make sure that you are in uniplanar, one plane of dissection. Go up to the blue zone of the trabecular meshwork and then just stop short so that you don't extend the edges of this flap anteriorly. Crescent dena. And now I'm going to move to the crescent to try and just extend this tunnel into the clear cornea. So just a little bit into the clear cornea and you're done. Side port. I'm going to make the side port for me to be able to maintain the chamber during the procedure. A small side port. And now I'm going to use the keratome to enter. Keratome. इसके बाद पंच चाहिए होगा. Wash कर देना बेटा. Make sure that when you're entering the keratome, you go up to the clear corneal incision you made and then enter. Because your punch will start cutting from there. Plain forceps दे देना मुझे. Plain forceps. So now just raise the flap gently and दूसरा पंच है क्या? It's too big. एक और पंच होगा इधर बेटा. I'm going to just change the punch. This looks a really large punch. Thank you, Vijay. So this is the Kelly's punch, and all you have to do is engage the lower lip of the incision, and you have removed the tissue. See how much tissue you've removed. Here you can see that I've got the corneotrabecular area punched, and then again another one. Make sure that you remove the tissue to know how much tissue has been removed. Wash kar do beta. So there you can see the window now forming. So we are good to go now. Yeah, PI करा दो बेटा. थोड़ा सा hydro दे देना. ये hydro. So I'm just forming the anterior chamber from my side port, little bit, and doing the PI. PI के लिए वानास दे दो बेटा. Wash कर देना बेटा. So the iris usually pops out once you have a good ostium formed. Just grab onto the iris and do a nice iridectomy. Make sure you have a full thickness. Yeah, 10-0 de do beta. The iris will fall back on its own the moment you tie the suture, and you can tap it gently. Suture 10-0 de dena beta, nylon. बेटा हाइड्रो दे देंगे मुझे और 10-0 दे देना. You can also pre-place the sutures in high risk cases and all. Thank you.
Dr. Reena, am I audible?
Yes, you are.
Okay.
So I've just formed the anterior chamber. A little 10-0 de do beta.
What size of the punch did you use, ma'am?
So this is a Kelly's punch. Usually I've been using Appaswamy punches, and they
Okay.
come only in a standard size. But out of the two, the first one looked a little big, so I let it go.
Okay.
So it's a standard size Kelly's punch. Wash kar dena beta. So I put 2 non-releasable at the 2 apexes and then 1 or 2 central releasables depending upon the filtration that I want to achieve. Thoda hydro de dena without suture time. I can also put an air bubble at this stage to maintain the chamber a little better if required. I'm still not putting it because I want to make sure that I get to see the PI. Suture time de dena. Next person here.
Did you use pilocarpine before?
No, it's just that you do not dilate the patient and then you don't really need
Okay.
any intraocular medication. So make sure that these sutures that you tie only just oppose your flap and they're neither too tight nor too loose. You can do suturolysis of these non-releasable ones as well in the post-operative period. Suture needle holder. And the releasables also help you modulate your filtration post-operatively. Beta wash kar denge flap area ko. So I'm going to just put the second non-releasable here. सर नहीं हिलाइएगा सर. आप ठीक हैं रावत जी? हाँ, सर हिलाए बिना बताइएगा. जी. So the second non-releasable बेटा McPherson चाहिएगा try के लिए ना. The slightly shorter bite should have been a little larger. Am I centered enough for you guys?
Yes, ma'am, you're centered.
Ah, the suture was broken, so you can see I still had an arm left here, but it came out. बेटा needle holder दोबारा दे दो. The important thing to remember when you create the ostium is that make sure the ostium's edge does not go up to the edge of the scleral flap to avoid overfiltration in the postoperative period. बेटा McPherson दे देना राजा. थोड़ा सा वॉश कर दो बेटा. The suturing is where you need to be a little meticulous and patient because that's what is going to determine the amount of filtration that you want to achieve. Scissor beta. Needle holder. So I've done my two non-releasable sutures and I'm going to put a releasable. What you can do for the releasable is to not have irritation for the patient, run it along the corneal limbus, the first bite, because you can just trim it off and it gets buried inside there. And then you can enter from the peripheral cornea and go towards the scleral flap to create a releasable. This way, the loose end is not there irritating the patient. So here I'm going to enter from here, come out of my scleral flap. That's it. So this elbow is what in the OPD I can pull out on the slit lamp and release my releasable as required. So here I've taken the bite. Just fill it up with a McPherson de dena Raja. So here I have the loop on the scleral flap and on the peripheral cornea. So I'm going to make it short here and tie my 3 to 4 throws for the releasable. Yeah, there you go. Now I'm going to titrate the filtration. Hydro dena beta. And make sure that we are happy with the amount of filtration I have and the pressure that the eye is. Vexel de dena beta. So I want some Vexel, dry Vexel sponge here. So just check the amount of filtration you're getting. You want an ooze. So here, very little filtration right now. You can see here. So what I'm going to do is release the releasable a little to get a little more flow and be satisfied. Thoda sa hydro aur dena. This is very important. To have predictable post-operative outcomes, it's good to titrate your bleb on the table. So see, it's quite tightly sutured and there's not much filtration happening, which means I have to loosen the sutures a little bit.
So you can just put a sponge near the edge and see how fastly or how quickly it is getting
Hydro.
absorbed. So it should be just slowly, it should swell up, not immediately.
Yeah, so see, what you want is that there is this amount of filtration. Can you see the oozing happening? Now it's not drying up. So now I'm happy and I'm going to cut the suture. What I have to do is pull it, get the end turning and go in. And then in the conjunctiva here, I press the cornea down and I cut it. It goes inside. So I have my releasable in place and the filtration seems adequate. ये ले लो बेटा suture. Vicryl दे देना मुझे. And I'll try and bury these knots into the sclera. To make sure that it does not bite into the conjunctiva later on. This is broken already. एक nylon organ. So see, you can see the filtration happening and the chamber is well formed and the eye is not too soft and not too hard. This is the end result that I want before I start suturing the conjunctiva back into place with Vicryl. 10-0 एक और दे देंगे बेटा, वो suture टूट गया था. कोई भी 10-0 दे दो. And this little patience to make sure that you're happy with the filtration on the table is highly recommended, so that you don't land up having unpredictable situations where it's over filtering or under filtering. You still have the releasable to play with, but just titrating it here at this stage is extremely helpful. So I'm going to just put another suture here. I usually use the round body 10-0 in trap. It allows me to cause lesser damage to the tissue while you're taking the suture bite, and these holes don't land up becoming a source of uncontrolled filtration. So I'm just going to tie another knot. These knots are 3-1-1, just enough to hold it down, but not too tight, not too loose. Sorry, focus it. दे दो बेटा scissor. ये Vicryl दे दो. So this one has gone into Vicryl दे देंगे. So I'm going to just put my conjunctiva back in place, and conjunctival suturing is extremely important because you don't want any leakage. The common post-operative problems that you see is leakage from the wound and overfiltration. So if you're just meticulous in closure of your conjunctival flap, then unlike it that you'll see any leakage, and you can also verify that on the table. So I take the bite and then I do a little running here to make sure that I have the entire conjunctival perimetry attached to my peripheral cornea. So I've taken multiple bites here. Because suture tying दे दो McPherson. Okay. So here again, you can just make sure that conjunctiva sits nicely opposed.
So, ma'am, you just took the conjunctiva, not the episcleral tissue. And
No, the first bite. No, the first bite you took was actually your peripheral cornea along with episcleral tissue. Otherwise, it's not going to hold down, right? So you're not tying the conjunctiva to conjunctiva, but to the underlying superficial cornea and the episcleral tissue. So I'm going to put two wing sutures and then the mattress. So see, this is the corneal episcleral tissue bite that I took on the other side as well. It's a longish one, so that it allows you to make the conjunctiva bound down nicely, so you will not have any leakages. I don't do just a single, so I run a little purse string. If you see, I run a little purse string. It just holds it down well and lesser chances of any leakages and all. De dena beta McPherson. So you can see this is going to just lock this down now. And the suture also gets buried under the conjunctiva. Although this will dissolve on its own, but it's just good to... और एक वाइगा ड्रॉप ऐसे ऊपर डाल देंगे at the end. So I've done both the sutures on the sides and one mattress in the center, one or two depending upon how well it's holding, and I'm done. And at the end we'll check the filtration once again. I think ये needle का suture ना टूट गया है, sorry. एक और Vicryl देना पड़ेगा आपको, या टेनो नाइलॉन या Vicryl दे दो अगर है तो. So you can see the releasable is visible, and this is the bent elbow that I'm going to pull out and release the releasable if I have to. I'm sorry, somehow the Vicryl needle has broken, so I'm taking another Vicryl suture, and I probably will need maybe just one mattress or two. So see, it's sutured till here, and here I have this much space open. I might put one or two mattresses here to make sure that the conjunctiva is nicely connected to the superficial cornea.
Which number Vicryl and needle are you using, ma'am?
This is Teno monofilament.
Okay.
So it's a very fine suture. The problem with 8-0 is that it's quick to close, but it causes a lot of inflammation. So I have given up on using 8-0 Vicryl. I use either 10-0 nylon even for this step, or so see, you use a peripheral corneal bite and then just get the peripheral conjunctiva into the bite, and then go back and then just suture it down like a mattress suture. Yeah. So here I'm going to go down. Yeah. It's very fine to see. So sometimes while suturing, you have to be a little careful. It's a very light colored suture and very fine because it's 10-0. Breaks very easily, but holds the wound down well. So again, the suture bite will go under the conjunctiva, so it's not going to irritate the patient much. Even if you leave it out, it softens up quickly, so there is no problem. You don't have to remove these sutures, only the releasable. Even if you don't want to release the releasable, you can just leave it like that. Otherwise, by the end of glass appointment, you can try and fix that. So now you have your conjunctiva nicely bound down. You can just check, and then I'm going to use some hydration from the side to see if this area is leaking. I will not hesitate to put another Vicryl suture to just make sure that it's a watertight trab of mine. Flat cannula head. Okay, so see the bleb has started to come up. Vexel de do bas. Vexel sponge. And just see that this is holding well and there is no leakage.
I
so
think
your
the
trab is
conjunctiva
done.
is nicely bound and
Yeah. So you'll
exactly
see that the
where
eye
you
is.
want.
Yeah, so this is what I want at the end. I want the bleb to filter well, the wound to be dry, and the side port is dry too. And then you can just give a subconjunctival injection and you're good. So the surgery is over.
Thank you, Dr. Reena, for a wonderful description of steps of a very important standard surgery, which is trabeculectomy. So, did you use a superior rectus?
No,
you don't.
No.
Okay.
So I'll show you how I managed to do it without that. If you look at this speculum, the upper arm is short and the lower one is large. It's called the Yamabashi speculum. This allows this longer arm inferiorly pushes the lower fornix so that you have the exposure of the superior bulbar conjunctiva. So you don't really have to give the superior rectus bridal suture to get the exposure. I've just given the subconj and Vigamox का एक drop डाल देंगे. डाल दिया. Surgery बहुत बढ़िया हो गई रावत जी. So the surgery is over. If you have any questions, I'm happy to answer.
Now, in the morning session, we had something about this MIGS.
Yes.
So, between trabeculectomy and MIGS, what is your take?
So you cannot compare the two. The MIGS right now, what is available here, the eye stent, is primarily recommended in open angle glaucoma in the early mild to moderate stages. What we are dealing with here is reducing the requirement of topical medication, making it from 2 to 0 or 1 to 0 or 2 drugs to 1 or 3 to 1. But trabeculectomy is primarily reserved for patients. It's a filtration procedure. So the two are not really comparable. You don't want to, normally if you look at the data, the MIGS is compared to only cataract surgery to evaluate how much IOP lowering the two are giving. So TRAB is really when you're dealing with moderate to severe glaucoma, where the patient is on 4 drugs, maximum medical therapy, whereas MIGS is, the role is a patient who has glaucoma and is going through cataract surgery and you want to help him lower the intraocular pressure so that the dependency on the drugs is reduced. That's when you will offer the MIGS.
Hello, Reena. In terms of failure, trabeculectomy versus MIG. So what do you think, like how do you put it, this factor? Because we have seen a lot of traps failing and we do not have much experience with the MIG, at least in India. Now we do not have much literature on this. So what do you think, like the failure rate of TRAB versus MIG?
So trabeculectomy failure rate now is becoming less and less because the trab is being modified more and more, and it still stands as a gold standard. And the long-term 5 to 7 years longevity of trab is now seen in almost 85 to 90% of the patients who are not the high-risk type, and we have enough data to establish that. But with MIGS also in the Western literature, we have lots of data. Long-term outcomes of the MIGS, I'm talking about only the eye stent, which is available in India right now, seems to be fairly good, but we have to understand what we are doing over here is actually allowing more filtration to happen through the Schlemm's canal, doing a microincisional surgery by putting these stents. So the amount of filtration enhancement that will happen is not comparable to TRAB. Failure in eye stents and all is known fact that the long-term IOP lowering effect might not be 10 years maybe shorter. You might even have to repeat. But because it's not invasive, it's not very invasive. Of course, it's invasive, but minimally invasive, the side effects of the procedure on the eye are much lesser, and you're still leaving a virgin conjunctiva behind for you to do a trabeculectomy at a later stage if required. So that's the important thing.
So you have very well shown the intra-op measures to check the failure. What do you do post-op workup to check the failure in trabeculectomy?
I think that's a brilliant question. Half the battle in maintaining a good bleb post-operatively in a patient is managing the post-operative period well. Because you can have wound leaks, you can have overfiltration, underfiltration. So if the bleb is not functioning well, it's easier to fix. You can release your releasables. You can do the suturolysis using your laser and Hoskins lens. You can give mitomycin C injection in eyes where you feel that the vascularization is increasing the scarring in the subconjunctival tissue. That also helps reduces massage in the postoperative period. Tomorrow in my video on saving the bleb, I'll be showing some of these tricks and tips to try and salvage your bleb. Also nowadays what I use sometimes in patients where the internal flap is kind of closing quickly or there is an iris occluding the ostium, you can go ab interno and release it. You can also sometimes do needling in the post-operative period to allow more filtration. So you have to pay attention to how the bleb is behaving in the post-operative period and how is the IOP, and then do the right things in the first 4 to 6 weeks for long-term good outcomes of your trabeculectomy.
Normally, for how long you advise the massage? Because massage is one of the very, very important, I think, part of post-op management of trabeculectomy. And how frequently and for how many days one should go doing massage?
So there's one situation where the massage is most helpful in my practices. Suppose I've done a laser suturolysis, and after doing it, if I give a small digital massage over the bleb area, I can see the bleb coming up and I'm getting those 5, 6, 4, 5 millimeter reduction that I want. That's the time when I'm going to teach the patient to do the massage 10 strokes at a time every 2 hours of the waking hours for a week and come back to me. If I see that the patient's IOP is doing well and the bleb is formed well, you can even just stop the massage now because you've given them the impetus in the initial phases of suturolysis for the flow to be maintained. And I also give the mitomycin C injections in these patients to slow down the scarring. So a week, 10 days where I know I'm achieving and I can let go of it. The other time the massage comes very handy is when I have pressures above target in the first 2 weeks, but I do not want to release the releasable yet. I tend to do the massage myself on the clinic to see if I'm able to express more fluid. That time I tell them to do the massage from the inferior bulbar sclera and only 4 times a day, 5 times compression. But these are all very subjective things. You can try and make a formula for your own self. But massage long term, I think, has no meaning. It's only temporarily when you're trying to work on the bleb, because after 6 weeks, enough scarring will happen and your wound modulation will not take place with massage. So whatever you do, it's the window of 4 to 6 weeks when all these things will work.
Madam, when you like to do the bleb revision?
Sorry?
Bleb revision.
Bleb revision. Now, bleb revision is a very vast, shall I say, title. So in bleb revision, there are 2 things. Once, when you have over-filtering blebs which are not responding to your medical management, like patching, giving aqueous suppression, forming the anterior chamber with air or sodium hyaluronate. In those situations, sometimes, rarely, but sometimes, unfortunately, you have to open the conjunctiva and put another suture onto the scleral flap. So that's one revision you might have to do. The other bleb revision sometimes is, which again I'll show you tomorrow in my video, is sometimes you have a buttonhole that would not heal with patching. It's not the edge which was not stitched properly, it's the buttonhole. And in that scenario, sometimes you have to go and do a purse string suture around that buttonhole to get it sealed. That's again, whether you call it a revision or a resuturing, you might have to do. Beyond that, one more technique that I use sometimes in the early postoperative period is I have a special flat cannula that you can put into the eye from the peripheral cornea under sodium hyaluronate up to the bleb side, which means at about 6 o'clock, and go towards the ostium. You can even use a gonioscope intraoperative if you like, and go through the ostium under the scleral flap and lift it to break the adhesions between the scleral flaps. That is something that I've started doing lately and works well in some patients where you've not achieved a decent filtration. Besides these, the early postoperative revisions, there's nothing much that I can think of that you would want to do or would be helpful.
Ma'am, advantage of injecting mitomycin 1 day prior in your patients?
Yeah, so I think it is the conjunctival edge and all that you've made secure, and it's a more diffuse injection given, which gives you a better wound modulation and lesser mitomycin C related complications.
So where do you exactly inject?
So what you do is you put paracaine in the patient's eye 1 day before. What I do is usually at the end of my OPD, preparing for the next day OT, all my trabs, I call them in the OPD at 5 o'clock. Put paracaine, tell them to look down, get your 0.5 ml, 0.1 ml MMC of 0.2 percentage ready, and give it like a subconj, actually subtenons injection, make a blister as far as possible from the limbus and the superior fornix. After giving that 0.1 ml, you withdraw the needle. If there's any outflow, you can wash it with sterile water, and then using your lid, your finger over the upper lid, just massage it towards the limbus, so that you've made the mitomycin C spread all over. And just leave them alone. And you can also inject it on the day of the OT, but at least few hours before. If you want, if you can't do it a day earlier, you can give it early morning on the OT day, and then after 5-6 hours, maybe take them up. But I find the conjunctiva behaves better if you give it a day before. But that's again a very personal thing, and it's a new thing that I've started doing only in the last 8-9 months. But I think the blebs behave very well and lesser leakages problem.